Um, Respected chairperson, distinguished pharmacologists, researchers, faculty, and dear colleagues, very good afternoon to all of you. So, first of all, I would like to thank my Director General, sir, for providing me this opportunity, and to IPSCON 2025 to providing me this opportunity to deliver a talk. So, I would like to explain today my experimental work on the topic treatment with pomegranate that attenuates tacrolimus induced nephrotoxicity via the mechanism is the suppression of oxidative stress apoptosis in Wistar rats. This is the experimental study. So, starting with the background of tacrolimus, as we all know that tacrolimus is a widely used immunosuppressant drug. So, here it is on right hand side you can see the chemical structure of tacrolimus. This moiety, this tacrolimus drug is being uh, produced from this bacteria, Streptomyces succubensis, from the soil samples which we derived from Japan in the year 1984. So this moiety produced from the fermentation of this bacteria. So it's a macrolide immunosuppressant, just like next generation of cyclosporins. It is a widely used calcineurin inhibitor and widely used in organ transplantation, in solid organ transplantation. It is indicated for prophylaxis of organ rejection in patient receiving allogenic liver, kidney, heart transplant, and nowadays for composite tissue transplants also we are using tacrolimus, both in the form of oral, IV, and even topical formulation of tacrolimus are also there, which we used in psoriasis treatment. So it is concomitantly used with the corticosteroids in kidney and heart transplants. It is used in conjunction with azathioprine or mycophenolate mofetil. So here's the first of all, I would like to explain the pharmacokinetics of tacrolimus because before proceeding with the tacrolimus induced nephrotoxicity, we have a brief introduction how this drug will work in our body. So it has a large variable pharmacokinetics. If we orally administer this drug, then the bioavailability varies from 5 to 93%. Oral doses of tacrolimus should be 3 to 5 times higher than the intravenous because it has a high bioavailability differences due to differences in CYP3 or 4 expression, drug-drug interaction, drug-food interaction, and certain other factors are also involved. So in most of the patient, it is absorbed rapidly with peak plasma blood concentration that would be observed in zero point 0.5 to 1 hour. However, we still see a lag time of 0 to 2 hour in case of transplant patient, liver transplant patients. So these are the absorption characteristics of tacrolimus drug. In GIT, this tacrolimus absorption significantly varies in GIT, as we can as we had earlier seen that it has high oral variability, oral bioavailability differences in their variation in uh, that. So careful monitoring of this drug, therapeutic drug monitoring is required in case of tacrolimus pharmacotherapies. And second, food interaction. Certain food intakes are also interact with this tacrolimus drug and cause interaction study because it increases the expression of CYP3A4 enzyme, that is metabolizing enzymes. So this is the biodistribution of tacrolimus. Tacrolimus significantly accumulated in liver, kidney, intestinal tissues following the oral administration, and higher doses lead to increased bioavailability, but higher doses are to be given with high dose adjustment because the major limiting side effect is nephrotoxicity. And these drugs show interaction studies also too. So drug interaction and patient specific factors also vary the distribution of tacrolimus. So, in metabolism, it is metabolized primarily by CYP3A4 enzymes. The average half life is 12 hours in stable healthy patients. Excretion is mostly via bile with minimum renal clearance involved. And for interaction, you have to monitor the patient. it caused drug-drug interaction as well as drug-hub interaction, and those which are CYP3A4 inducers and inhibitor, you have to adjust the dosage also when you are concomitantly administered with these inducers or inhibitors. So this slide shows the global perspectives on tacrolimus use. See, tacrolimus is widely used in transplant patient because of its high potency, and it is widely used throughout the world. But it has two major challenges. First, major challenges which many transplant registries in USA, Europe, and Japan, Asia, they showed that it has 30 to 50% of patients they had nephrotoxicity as their dose-dependent nephrotoxicity. The tacrolimus drug showed in their patient data, and second is variation in kinetics, pharmacokinetics of this drug. So this has two challenges with tacrolimus drug. So in 1, 2, 3, 4, 5, I have highlighted certain different regions, and they have observed some challenges with the tacrolimus. In case of one, the higher tacrolimus concentration observed in tissue samples, a significant variation in pharmacokinetics among the individuals of ethnic origin. In Asia and in Europe, they have different CYP isoenzymes, and that would differ the pharmacokinetics of this tacrolimus drug in different regions. So, notable adverse effect, that is nephrotoxicity, is the most notable adverse effect. So, first of all, I would like to explain the mechanism of tacrolimus drug. It bind to the intracellular receptor and significantly bind to calcineurin. We can call tacrolimus as calcineurin inhibitor also, because it inhibit this calcineurin, and this further inhibit the NFAT pathway. You had studied this in your pharmacology textbooks. So this will decreases the IL-2 interleukin 2 expression, and further it suppresses the T lymphocyte activation. So likewise it causes its immunosuppressive effect. So this is the mechanism how the tacrolimus drug it in the cells how it got uh, how it works. So it decreases the activation of T lymphocyte cells. How it decreases? By binding to these FK506 binding proteins, that is FKBP. Tacrolimus binds to this FKBP, and subsequent inhibition of NFAT, nuclear factor of activated T cell target genes, and thereby contribute to immunosuppression. So, the major dose limiting toxicity is tacrolimus nephrotoxicity. That I already told that certain uh, transplant registries show that 30 to 50% of patients have nephrotoxicity due to this drug. So, both type of nephrotoxicity we have observed, acute as well as chronic, but because it shows dose dependent, so there are more chances of chronic nephrotoxicity. So how it causes? It causes the tubular atrophy, interstitial fibrosis, arterial helionesis, and the mechanism is due to increase in ROS, mitochondrial dysfunction, ER stress, and activation of apoptotic proteins. Caspase 3 VAX are pro-apoptotic factor, and BCL2 is anti-apoptotic factors. So it causes nephrotoxicity due to these three or four possible mechanisms. So this is the impact of tacrolimus on PCT cell. In our neuron, we have PCT, DCT, and convoluted tubule, as we all know. So on proximal tubule cell, this tacrolimus causes excessive loss of sodium ions due to these mechanisms, due to shortage of time. So I'll straightforward come to my experimental work. So first of all, the research question is uh, actually the tacrolimus cause severe nephrotoxicity. So we need some protective agents that will reduce its nephrotoxicity and that will not interact with tacrolimus drug. So first is treatment of, so my research question is treatment with pomegranate, that is herbal therapy, which have possible antioxidant, anti-inflammatory, and anti-apoptotic role. It attenuates the tacrolimus-induced nephrotoxicity via suppression of oxidative stress and apoptosis. So the primary objective is to evaluate the protective effect in this tacrolimus-induced nephrotoxicity model, that is of 4 weeks model, and secondary objective is to evaluate the assessment of renal function, serum creatinine, BUN levels, oxidative stress markers, histopathological analysis uh, to evident the change in change in pathological changes in kidney tissues, and the expression of apoptotic markers. So this is the gap that as we all know, that we do not have any specific antidote to counteract this tacrolimus induced nephrotoxicity. We have two things, that either we can reduce the dose, in that case we have rejection risk, or either we can supplement it with calcium channel blocker, but that have partial benefit. So by these two is the management process. So we need a safe, natural, antioxidant rich adjuvants that do not interact with this drug and possibly provide the nephroprotective action. So I have selected this Punica granatum. As we all know, in Unani it is called as Gulnar. And for this study, we have used the dried pomegranate rind extracts, because the rind extract is rich in ellagic, punicalgin, and anthocyanin, and these have powerful antioxidant, anti-inflammatory, anti-apoptotic in multiple models. They have documented this thing, and rinds have more quantity of these polyphenols. So we have selected this extract. So study design is male with star rat we have chosen. The duration is 4 weeks, 28 days. Group is N is equals to 6, and we have 4 groups. First group is our normal control. Second is we use tacrolimus in a dose 3 mg per kg by oral route. And then we have 3 subsequent groups with pomegranate in different doses, that is 50, 100, and 200 mg per kg. And this dose is calculated uh, after conducting the toxicity studies. And the per se group, pomegranate extract alone group. So the parameter we have studied is renal function, oxidative stress, histology, and apoptosis. So these three are the selected doses for punica granatum. This is the IAEC number, and prior to experiment, the animals are fully acclimatized according to humidity and temperature condition. So this is my nephrotoxicity model. We induce the nephrotoxicity of tacrolimus in Vistar rat on day 0. We administered our test drug, because it's a pre-treatment, it's a protective effect. So we administered the test drug subsequently for 28 days, and on after 1 hour on day 1, tacrolimus was administered per oral, except normal control group. And on 28th day, we assess all the parameters, the kidney function test, the histopathological examination by sacrificing, and immunohistochemical, and all the apoptotic markers. So these are the results of my study, that you can see that the first table described the serum creatinine and BUN level. In second serial number 2 in the table, the tacrolimus 3 mg per kg had significantly increased serum creatinine. The normal value of serum creatinine is 0.9, but tacrolimus increased the creatinine value to 1.5 and BUN value to 82.83. But with in case of PG uh, dose, this value got decreased, and the most potent dose is PG 200 mg per kg. Likewise, in second table, we had shown the antioxidant parameters, glutathione, SOD, MDAT bars. This is the histopathological and immunohistochemical analysis of Punica granatum. As you can see, the figure B, it shows some tubular atrophy in these sections of PCT. So it shows tubular atrophy, which was decreased in section F, and section E, that is Punica granatum 200 mg per kg. Likewise, this is the immunohistochemical analysis of caspase 3, BCL2, and BAX proteins. It uh, one thing in this slide is that it increases the expression of BCL2, that is our anti-apoptotic protein, and the pro-apoptotic protein, that is caspase 3 and BAX. It decreases the expression of these, as it is clearly evident from the immunohistochemical slides. So, I had also conducted the toxicity study, the oral toxicity study, acute toxicity study, and provided that this is the toxicity study of our test drug, Punica granatum. So, we observed all the animals for 10 days, and this is the experimental model for 28-day oral toxicity study, that is subacute model. And both these experimental procedures were conducted as per OECD guidelines, OECD 425 for acute and OECD 407 for subacute toxicity studies. So these are the observation that in our Punica granatum extract, none of the animal died for days when we observe the mice for 10 days. And this is the subacute toxicity studies. And these are the biochemical and hematological parameters which are in normal range. So this is the pathological analysis of Punica granatum in subacute study. Okay. So this is the conclusion that we had evaluated the Punica granatum rind hydroalcoholic extract. We have evaluated the biochemical parameters, serum creatinine, blood urea nitrogen, and TNF alpha level. These got decreased when we administered the group uh, with the pre-treatment of Punica granatum. The antioxidant parameters, MDA level decrease and GSH and SOD level increase. Histopathological, the PG supplementation showed normal architecture of kidney and no signs of tubular damage. And in immunohistochemical analysis, the Punica granatum attenuated the increased level of various biomarkers. So, Punica granatum demonstrate nephroprotection in tacrolimus induced nephrotoxicity model, and it is safe in acute as well as subacute study. We observed no biochemical hematological changes as well as no pathological changes were observed in any of the section of liver, heart, kidney, testis, stomach, spleen, ovaries, and brain of male and female rat as we compared them with the normal rats. So thank you. If you have any questions, I'm happy to answer.
We will be having questions. Okay, okay. Thank you, Dr. Ritu, for the comprehensive presentation. Do we have any questions or suggestions or any observation? Because she'll be leaving, she has to catch a flight. Okay. Thank you, Dr. Ritu, for such a enlightening and influential talk. Now I request chair session chairs to kindly facilitate. Ma'am.